The broadcast is now starting. All attendees are in listen-only mode.
Hi, it's Michael Walton from Biomedical, Senior Application Engineer.
I'm Andrew Davis, Business Development Manager.
I'm going to be taking you through a presentation on vital signs simulation. Main vital signs simulation revolves around blood pressure, non-invasive blood pressure, NIBP, invasive blood pressure, IBP, pulse oximetry, electrocardiograph, ECG, respiration and temperature. So typical test cycles for patient monitors are visual inspection. Sometimes the medical device will do some self-testing. There's an electrical safety test, whether that be 60601 or 62353, depending on what your healthcare organisation has stipulated. Then we do integrity testing, which perhaps might be a leak test or overpressure testing. Parameter accuracy, so anything that is measured. Patient checks, speed and amplitude of a printer or any printouts. Alarm checks, which perhaps might be pitch, frequency or volume. And any physiological simulations like NIBP dynamic and IBP dynamic pressure simulation. So a visual check, a visual test. We look at the housing, the enclosure, damage, cracks. We look for contamination, look for any obstructions of any moving parts, make sure everything is mechanically sound. Cabling, is the supply okay? Do the applied parts look sound? Is there any cuts or wrong connections in any of the cabling? Is the fuse rating correct? Check the correct values, and if a replacement is required, then replace that. Is the marking and labelling correct on the patient monitor? And the integrity of mechanical parts, check for any obstructions. So a little bit on the theory. The respiratory system, all vital signs are related to the operation functioning of the respiratory system. So the heart circulates blood through the body in the lungs. Oxygen attaches to hemoglobin protein in the red blood cells, reaching the brain tissues and organ tissues in order to sustain life. Acts as two pumps. Oxygenated blood flows from the lungs through the left side of the heart, whilst deoxygenated blood flows from the tissues through the right side of the heart to the lungs in order to reoxygenate blood cells. A little bit about the cardiac cycle. So the cardiac muscles are electrically stimulated with the SA node, the AV node and the bundle of His. I'm not going to go into massive detail on that. We will have a webinar perhaps in the new year which will go into more detail of the cardiac cycle when we do defibrillation. Chambers fill up with blood during the low pressure diastolic phase when the heart muscle relaxes, then pressure builds up in the ventricles that provide the required condition to allow circulation, which is the high blood pressure phase and the systolic phase. A complete cardiac event is referred to as a cardiac cycle. A single heartbeat involves atrial systole and ventricular systole, and then complete cardiac diastole. So blood pressure. Blood pressure, the most common vital sign parameter being monitored or measured, is the arterial blood pressure. So blood flow and pressure change with each stage of the cardiac cycle are reported in millimeters of mercury. In a healthy patient, the average values for this are typically 120 millimeters of mercury for systolic, 80 millimeters of mercury for diastolic, and for mean pressure 90 to 93 millimeters of mercury, where mean pressure is the following equation that we've got displayed there. So non-invasive blood pressure, we have palpitation, which is pretty crude, and it's the sensing the pulse and pressure at various places of the body. And then we have auscultation, which is determining systolic and diastolic pressure through blood flow through sounds of the artery, which is the coracoch sounds. They're accurate, but they're difficult to automate, where effectively you would be using a pressurized cuff around the arm, and you would be using a stethoscope to monitor blood flow. And then we have the oscillometric, which is automatic, and we determine systolic and diastolic based on mean arterial pressure and acoustic profile. Accuracy determined by many factors like leaks, the acoustics of the cuff, and tightness. Effectively, in the diagram, what you have is the pressure transducer. So you go to the point of you pressurize the cuff to the point of no blood flow, and then once you start seeing deviations from a pressure transducer, those deviations would be the systolic, and those pulse volumes will die off until you see the diastolic. So why test NIBP? Have you got leaks in your cuff or in your pressure system? You want to check the overpressure valve. You want to check the pressure transducer variation. Does it produce linearity in readings? Because a pressure transducer, being a mechanical device, can vary when it comes to metrology. So the linearity is very important. And then dynamic pressure. Manufacturers of automated NIBP monitors use different algorithms to determine systolic and diastolic pressures, pretty much based on different interpretations of pulse volume dynamics. What we provide, or Rigel provide, is an instrument to simulate those characteristics. So we have oscillometric pressure simulation for adult neonates. We have pulse volume adjustment. We have custom static pressure tests, custom O curves, which are manufacturer specific. We have system leak tests, system over pressure tests, and a digital manometer. IBP. IBP is the arterial pressure and can be measured in real time with a high degree of accuracy. Well, liquid, where we have pretty much a catheter that's placed in the artery that's filled with liquid, and the pressure, or the atrial pressure, is transferred via the liquid inside the catheter to a pressure transducer. So what the patient monitor is doing is it will output an excitation voltage, and the pressure transducer will proportionally put out a millivolt, which is proportional to the millimeters of mercury. So sensitivity is typically, for most patient monitors, 5 microvolts over the excitation voltage. So why do we test IBP? Pressure transducer performance. Again, linearity and static pressure. And when you would calibrate these things, both with NIBP and with IBP, static pressure is pretty much key to get stable linearity readings. And then we'd look at alarms, testing the alarms of the patient monitor. And then we'd check dynamic pressure, hypertension, normal, and hypertension. So what do we provide with our biomedical test solutions in patient simulation? We have dynamic and static pressures. We have 2 channels of IBP. We have configurable systolic and diastolic readings or parameters, and we go from 0 to 300 millimeters of mercury. So, SpO2 is the assessment of the amount of oxygenated blood cells in relation to deoxygenated blood cells. And in a healthy patient, typically 95 to 100%. Non-invasive technique using different light absorption characteristics, where we have a graph there at the side where we have red waveform, which is typically 650 to 700 nanometers, and infrared, which is typically 850 to 950 nanometers. And effectively, what the SpO2 is doing, according to that graph, is it will look at where the oxygenated hemoglobin is and the reduced hemoglobin is, and then it can determine the ratio of SpO2. So, for instance, if there's more red than infrared light is being absorbed, then there's going to be less oxygenated blood. Therefore, you would have 0.5 ratio or 0.5 ratio, would be 100% of SpO2. So in principle, this translates to less infrared than red light being received, higher concentration of oxyhemoglobin. Less red than infrared light being received, lower concentration of oxyhemoglobin. Why test SpO2? Because we could have faulty probes, LEDs might degrade over time. We might have a mix match of probes and monitors and deviation in wavelengths, because critically most SpO2 manufacturers will choose different wavelengths to determine different ratios in their own algorithms. You might have a contaminated lens, or the probe window might be contaminated, damaged wiring or patient cable, inaccurate calibration of the SpO2 monitors. So we again look at linearity of parameters and measurement and testing audible alarms. It's also important to display the plethysmograph to make sure that it has the correct characteristics as per service manual. So what do we bring as a solution? We have our Rigel Pulsar Simulator, and it's a universal simulator accessory, which is a large number of R curves. The R curves are the different manufacturer algorithms, and you can customize and fully user customize the R curves for full flexibility. SpO2 goes from 30 to 100%, and we can monitor extension cables and sensors are tested at the same time. So there's just an example of some of the manufacturers that we can simulate and our compatibility with our Pulsar instrument. It has 2 LEDs. Those 2 LEDs make sure that they indicate whether a probe is correctly aligned and connected. ECG. So there's a picture of the complex QRS, and with the complex QRS we have the P wave, which is generated during the atrial depolarization, which is the contraction of the muscle. Following this, the right and left ventricles are depolarized, again they contract. That generates the complex, or the QRS complex. Then the T wave is when the ventricles repolarize it, repolarize. The repolarization is when the muscle is at rest, and when the muscle is at rest, it does not respond to any type of stimuli. The atrial repolarization is during the complex, or the QRS complex, so you cannot see any type of waveform to relate to that because it's hidden by the depolarization of the QRS complex. The T wave is the most vulnerable part of the ECG cardiac cycle. Any disturbance during this repolarization phase can send the heart into fibrillation. So we have Einhorns Triangle. Typically we're looking at lead 1, lead 2 and lead 3, where lead 1 is left arm and right arm, lead 2 is left arm and right arm, and lead 3 is lead 2 is left leg and right arm, and lead 3 is left leg and left arm. And there's a characteristic showing you a graphical representation of what a typical lead 1, lead 2 and lead 3 scenario should look like. Notice that on the graph you have a square wave. That square wave, that pulse, is generally the calibration pulse to check to see whether the printout or the displayed ECG is within 1 millivolt calibration. So an ECG machine, the electrical potentials are amplified, measured and displayed on the screen. Typically we can change between 3, 5 and 12 lead configurations. Placements of the ECG leads are standardized, so the interpretation of ECG is consistent. And some ECG monitors and patient monitors can diagnose or confirm cardiac conditions, which is the arrhythmia like tachycardia, bradycardia and myocardial infarction and ischemic conditions. So why do we test ECG? We want to look at the linearity of the heart measurement. In regards to beats per minute. We want to look at the QRS beep, the frequency and the pitch of the beep to make sure that it coincides with the R wave, because this is a clear indication for clinicians to follow. We look at alarms, the settings of alarms, the high and low settings of alarms. We look for the alarms of a disconnected electrode. We can look for arrhythmias like a systole and other arrhythmias that perhaps might be in a service manual to look at. Other ventricular and atrial conditions. The sensitivity test and is the gain change of a monitor, either via a graph or displayed on the screen. And then we have zero offset, which is your ISO electric line, which is pretty much the baseline for your ECG. We can check the frequency response, notch filtering, which will reject 50 and 60 hertz noise, low pass filtering, which will reject other noises which is not relevant to ECG measurement, and high pass, which will reject very low frequency that could disturb the isoelectric line. We're looking at printer calibration, amplitude and timing. So you see a graph on the screen there which has amplitude and has the timing of the actual graph itself. So we can output square waves, sine waves, triangle, dependent on what the service manual is asking for with the patient monitor or ECG monitor. What do we provide with our solutions? We have a number of different ECG waveforms covering a multitude of different conditions, from normal sinus rhythm to SV elevation, myocardial fraction. We have atrial conditions, ventricular conditions, performance waveforms, and pacer waveforms. Respiration. The thoracic cavity volume is increased as a result of involuntary contraction of the diaphragm. In addition to the diaphragm, the intercostal muscles also aid the breathing process by lifting the lower and upper ribs. Expiration of the lungs is a result of the is a result of the lungs just going out a bit, forcing air out when the diaphragm and the intercostal muscles relax. Monitoring the respiration rate on patients is pretty much vital during surgery to make sure that any changes in respiration rates are viewable, and alarms or correct alarms can be set up. Most commonly used is the measurement of the transthoracic impedance between the ECG leads, either 1, lead 2 or lead 3. Typically lead 1 and lead 2 are changed, where you might have, as far as the simulator is concerned, 500, 1000 ohms, and then the breathing rates or the respiratory rates are the delta resistance, which is the change in resistance, which is very small changes, typically half an ohm or 1 ohm. And so when the thoracic cavity expands, in the impedance of the chest will change, and that's effectively what a patient monitor will pick up. Why test respiration? The linearity of respiration rates, sleep apnea, which is when there isn't any respiration, and the alarms of respiration. What solutions do we provide? We provide, as far as the UniSim is concerned, right arm, left arm, lead 1, respiration, range of breaths per minute, apnea, simulations, different base impedances and different delta resistances. So temperature, the average core temperature is 37 degrees Celsius plus or minus half a degree. The most common temperature sensors used on bedside monitoring are electrical safety or electrical temperature sensors, which are thermistors. These thermistors are typically NTCs, or negative temperature coefficient probes or sensors, or positive temperature coefficient sensors. Both are non-linear, and here's some typical values that you would see of body temperature. And then we have different YSI values, which typically tie into different probes, but YSI 400 is probably the most common in patient monitoring. Why test temperature? Again, we're looking for linearity of temperature measurement. We're looking at alarms, high and low alarms, to ensure that a patient isn't overheating. And then we want to make sure we've got the correct temperature sensor set up on our monitor. What do we provide as far as solutions? We provide YSI 400 and 700 simulation, and we simulate various amounts of different temperatures. Right, I'll just hand over to Andrew so you can give the demonstration.
Biomedical offers a number of solutions for calibrating patient monitors. Today we are going to be looking at the UniSim, which is our all-in-one patient simulator, as well as our newest in the range, which is the PatSim 200. Typically, a biomed or service engineer may carry a number of pieces of equipment around with them, a dedicated SpO2 tester, dedicated non-invasive blood pressure simulator. The UniSim is a 6-in-1 solution. It's very portable, as you can see, it fits in the palm of your hand, and it'll measure the parameters of SpO2, non-invasive blood pressure, invasive blood pressure, 2 channels, temperature, respiration, and various ECG waveforms. Key features of the UniSim: it is handheld, battery powered, so you do not need mains, making calibrating one of the monitors very efficient, very portable. It has a Pulsar optical finger, meaning that you don't need various different technology types. The curves can be loaded into the UniSim, meaning that multiple monitors can be simulated using the same solution. We have one button simulation, very straightforward to set up. You can program various different patient conditions. It's got an onboard memory that's built into it, so you do not need a designated software package, for example, to store results. You can store it all within the same UniSim memory, and however it is also fully downloadable to a PC for full traceability. The PatSim 200 is a full 12-lead ECG patient simulator. It has over 40 selectable arrhythmias, various performance waveforms. It's capable of simulating respiration, lead 1, lead 2, temperature, 2-channel invasive blood pressure, and it also has the fetal simulation feature built into it. You can see it has a very large colour display, very quick to use in terms of selectable parameters within the tester. It's fully rechargeable, and it'll give up to 6 hours of operations between charges. Universal ECG studs to connect to various types of monitors. It has a designated home navigation button, and it also is supplied with a robust carry case to protect your simulator. It has a unique feature where you can store up to 5 commonly used test sequences and recall those very quickly, just simply using the F keys on the front of it. It will give you a full on-screen waveform for quick reference. It is very cost effective, and it is complete with peace of mind 5 years manufacturer's warranty. We have set up here with the UniSim, measuring this particular monitor has the facilities of ECG, SpO2, respiration, IBP, temperature, and non-invasive blood pressure. You can see that the simulator is simulating all 6 parameters at the same time, making calibrating this monitor very time efficient and very simple to use. You can also select using a couple of key buttons. You can change the parameters very simply, and the monitor will respond to that, making the calibration very straightforward. Patient simulator, you can see very clear display, very simple to select the various different parameters that you're looking for. Just simply using the F key, it will select whether performance waveforms, arrhythmias, and also has pacer waveforms inbuilt as well. Other parameters built in with the temperatures, your respiration, your temperature, and your invasive blood pressure.
Right, so that's the end of the presentation. If anyone has any questions, just email the following email that's on the screen there, we also have some guidance, which is the introduction to measuring and simulating vital signs. So if you want any further information or pretty much an in-depth explanation of this whole presentation, then you'll probably get better insight and more detail from downloading that from our website, which can be found on the download section of the RIGEL website. Thank you for watching.
Thank you.